Good afternoon, and welcome to the YAA session of 25th ASEAN Federation Cardiology Congress. My name is Lungrod Pediapong from Thailand. I will be the chair of this YAA session. Today we have 8 presentations from 8 countries. And I would like to name all the judges who are representative from Asian countries as follows. Sofian Johar from Brunei, Sokcho from Cambodia, Isman Ferdas from Indonesia, Lam Kai Huat from Malaysia, Ronald Cuello from Philippines, Lim Chun Vai from Singapore, then One Phoc from Vietnam, including myself. And without further ado, I would like to proceed with the first presentation. Each presenter will have 7 minutes for presentation and 3 minutes for Q&A. The first presentation will be transit time flow measurement as a predictor of graft failure and major adverse cardiac event following coronary artery bypass graft. Will be presented by Yong Hong Jun from Brunei, please.
Hello, my name is Yong Hong Jun. I'm from Universiti of Brunei Darussalam, and today I'll be presenting my research titled Transit Time Flow Measurement as a Predictor of Graft Failure and Major Adverse Cardiac Events Following Coronary Artery Bypass Grafting. CABG is performed in Brunei only if patients present with stable ischemic heart disease, with the grafts Lima to LAD and Saphenous vein being the most utilized, while radial artery is occasionally used in younger patients. 100 CABG surgeries are performed in Brunei each year. Post-CABG, the gold standard for assessment of graft patency is usually done with an angiogram. However, adopting mainstream guidelines, patients in Brunei only receive an angiogram post-CABG if they present with ischemic signs such as angina. In recent years, the use of transit time flow measurement, or TTFM, which is an ultrasound probe used to assess quality of blood flow in the graft, has been more heavily utilized and has been adopted by Brunei for years to assess overall quality of blood flow in grafts directly after graft insertion. 3 numerical parameters make up TTFM, with Q mean indicating rate of blood flow per minute, PI, and index of resistance to blood flow, and diastolic filling, indicating percentage of blood filling the graft during diastole. So what do these parameters mean? Grafts with a TTFM value meeting their criteria of their cutoffs are defined as satisfactory grafts with high quality blood flow. This means that grafts with a Q mean of more than 20, PI less than 5, and DF more than 50% are labeled as satisfactory grafts that do not require intraoperative graft revision. With the limited use of post-CABG angiograms in Brunei, we wanted to see if TTFM could be used instead as a parameter to predict post-operative outcomes. Studies have shown its benefit in assessing graft function intraoperatively, but limited studies show its significance in assessing long-term patency and clinical outcomes. Therefore, the aims of this study are to profile the grafts and TTFM parameters in Brunei over a 3-year period, assessing differences in TTFM across different graft subtypes and associations between TTFM parameters and post-operative outcomes. In this study, to define graft failure, we characterize grafts with 50 to 100% stenosis to be failed, and any grafts with less than 50% stenosis are considered normal. In this retrospective cohort study, we recruited 279 patients in Gleneagles JPMC, Brunei's main cardiac hospital, who underwent an isolated CABG procedure from 2017 to 2019. We collected patient sociodemographics and comorbidities. In this patient population, 26 patients were identified to have a post-operative angiogram. We assessed their patient files and angiogram reports for outcomes of graft failure and MACE, in which we conducted a variable follow-up period until the end of 2020. We defined MACE as a prevalence of one of the 3, angina, and MI, or death. Lastly, these were the utilized statistical tests in this study. So based on the patient sociodemographics of all 279 patients, majority of the population are males of the Malay race. It is also no surprise that these patients have various risk factors of severe atherosclerotic disease, such as high BMI, age above 50, diabetes, hypertension, and hyperlipidemia, indicating them for CABG in the first place. Around 60 to 70% of patients also have a history of MI or stable angina. Now, zooming in on the post-operative outcomes of the 26 patients who've had a post-operative angiogram, there's a high percentage of arrhythmias, cardiac arrest, post-operative intra-aortic balloon pump needed, and congestive heart failure. And approximately 40% of them had an angina or an MI, which makes it clear for the need to conduct an angiogram for this very sick population. When taking a look at the type of CABG grafts done in Brunei, we see that most of the grafts used graft to vessel combination is the LEMA to LED, while other graft to LED combinations are very rarely used. However, the saphenous vein graft in general is more commonly utilized. Taking a look at our angiogram findings with a follow-up period of until 2020, out of all the grafts, only 28 of them failed. So this gives about a 3% failure rate out of the entire graft population. And majority of these grafts, about 60% of them, actually failed after a 1-year period. It took a median of 382 days for patients to present with clinical ischemia and require an angiogram. And majority of these patients, about 77% of them, required a PCI along with the angiogram. So taking a look at the type of grafts more likely to fail, we see that the radial to LCX has the highest likelihood of graft failure at about 15.4% with statistical significance. So when we compare TTFM parameters across different graft subtypes, we noticed that actually arterial grafts had a lower PI and higher diastolic filling compared to venous grafts, which also corresponds to LEMA grafts having lower PI and higher diastolic filling than saphenous vein grafts. So based on the cutoffs, this indicates that overall LEMA grafts have better blood flow and higher quality blood flow overall. So our finding in Brunei's graft database, with the majority of graft vessel combinations used were the LEMA to LED, in line with best clinical practices to prioritize the use of LEMA graft to bypass LED occlusions due to its improved quality of blood flow, which is consistent with the study's findings of a lower PI and higher diastolic filling percentage of LEMA grafts in comparison to others. However, when comparing TTFM parameters in terms of functionality, there was no statistical difference between failed and normal grafts, which gives us an idea that TTFM might not be significant for graft failure in the long run. One thing to note is that the proportion of failed grafts with PI 5 or more is more than the failed grafts with PI of less than 5 when comparing based on recognized TTFM cutoffs. This suggests that a PI of more than 5 is the only significant TTFM parameter which could correlate with graft failure. So when referencing the literature, there also shows limited significance of TTFM in predicting graft failure or other adverse clinical outcomes. However, there are studies which show that the use of angiogram in all CABG patients has some association of TTFM with graft failure. This is in fact a big limitation of our current study, where there might be a large proportion of asymptomatic graft failure missed in patients who did not present with clinical signs of ischemia. Our study by Kiza et al. Also showed that the significance of PI more than 5 in predicting graft failure and MACE, which confirms this study's findings and can be considered when assessing for risk of long-term graft failure. Lastly, based on a multivariate analysis, it was found that TTFM showed no association with graft failure and MACE. There was statistical significance of an increase in Q mean correlating to increased risk of MI. However, it is not clinically significant. Instead, a wide variety of clinical demographics and comorbidities increased the risk of one of the 4 clinical outcomes. However, the absence of renal disease increasing risk of MI also shows no clinical significance. The main limitation of the study was as discussed, with a high rate of underreported asymptomatic graft failure. We would recommend adoption of routine angiograms in all cardiac units in Brunei, similar to protocols conducted in Japan. In conclusion, despite TTFM's association to graft failure and MACE being inconclusive, it still remains a valuable and convenient intraoperative assessment to determine short-term patency. Surgeons should ensure good TTFM values intraoperatively and instead pay closer attention to patient comorbidities as a predictor of adverse outcomes after CABG. So I would like to thank the following individuals for contributing to this project and making it a success. These are my references, and thank you for your time.
Thank you. We have 3 minutes for Q&A, please. Just.
Yes, I'm Dr. Sokyo from Cambodia. So I think it's very interesting technique, useful, and I would like to know if during the operation, if you find that the flow is not good, what do you will do? You will reoperate the bypass, or what you will do?
Yep. Hello. Yeah. Hello. My name is Dr. Hong Jun. Yeah. So to answer that question, yes. So usually in cardiac units which utilize TTFM as an intraoperative parameter, they usually depend on it to whether to assess for the need of graft revision intraoperatively. So say, for example, a surgeon notices that the graft has a Q-mean of less than 20 or a PI of about 10. So this would entice the surgeon to possibly look for any abnormalities or kinking of the graft, and it will encourage the use of graft revision until the flow is satisfactory. Yeah. Hope that answers your question.
Okay. Hi, my name is Dr. Cinco. Congratulations on your paper. I thought that was well written and very interesting. My only question is, how many patients in the end did you analyze? 29, is that correct?
So to clarify, we identified about 279 patients. However, out of these 279 patients, we did identify only 26 patients with a post-operative angiogram. So 26. You can think of it as us, 26 with a post-operative angiogram.
So my question relates to sample size. Do you think that sample size of 26 will be enough to make a conclusion based on your paper? Thank you.
Yeah, unfortunately, due to the limitations and time constraint of this study, right, we weren't able to receive enough patients who've had a post-operative angiogram. So it does indeed dilute the overall power of the study. However, for future recommendations, right, and future studies, we're actually planning to shift the time frame of study towards somewhere around 2005 to 2015, so that we might get a longer period of angiogram, so that we can actually standardize the follow-up period following that time frame, so that we can actually get a wider population of those requiring a post-operative angiogram. So it might actually increase the power of the study. But as of now, it's difficult to say because of the limitation of asymptomatic graft failure. Yeah. I hope that answers your question.
Thank you. If there's no more question, thank you. We move on to the second presentation. Second presentation will be treating no-reflow with distal injection of cocktail Verapamil, Nitroglycerin, and unfractionated heparin during primary angioplasty in acute myocardial infarction case series. Will be presented by Dr. Sam Samrany from Cambodia, please.
Good afternoon, ladies and gentlemen. I'm Dr. Sam Samrany from Cardiology Department, Calmette Hospital. It's my great pleasure to be here. Today, I present on my topic treating no-reflow with distal injection cocktail of Verapamil, Nitroglycerin, and unfractionated heparin during primary angioplasty in acute myocardial infarction case series. No-reflow is a direct complication and associated with poor prognosis. The phenomenon observed more than 50% in STEMI, especially in high thrombic region. In recent study, the incidence of high thrombic burden in STEMI is higher in Southeast Asian countries. We report case series during no-reflow in STEMI with light thrombus using modified technique stenting after distal embolization of flask. First case, 67-year-old male smoker present with inferior MI, complicated cardiogenesis shock, and complete heart block, follow 27-hour history of chest pain. Temporary pacing was insert, emergency coronary angiography, so occlusal proximal or OCA. Thromboaspiration was performed without restoring the flow. Then, ballontic dilatation was done repeatedly, failed again to restore the flow. Distal intracoronary flask cocktail was injected by nitroglycerin 100 microgram, Verapamil 100 microgram, and heparin 1000 units at the distal OCA by using aspiration catheter. We got the flow timid through which light thrombus at the mid OCA. Thromboaspiration was done again and we got some light thrombus. After aspiration, angiography revealed severe stenosis at the mid OCA. 3.030 mm stent was deployed at the lesion. Finally, we got the good result with timid reflow. The patient was discharged on day 10. Second case, 60-year-old man with history of hypertensive active smoker and diabetic, present with acute inferior MI for 12 hours. Coronary angiography for total occlusion of the distal OCA. After several predilatation, distal flow was not restored. whole balloon was used to inject flash cocktail into the mid part of PL breast. Per procedure, angiography reveals severe stenosis of distal OCA with TME1 flow. 2.75 30 mm stent was deployed at the lesion. We got the final good result with TME3 flow. But the patient was discharged 4 days later. The last case, 62-year-old man with hypertension, diabetes, and active smoker present with ongoing severe chest pain since 4 hours ago. He had history of inferior MI. He is previous coronary angiography. He had dual vessel disease, occlusion proximal OCA, 2 stent was implanted at proximal and mid part, which other lesion CTO proximal LCA was planned state PCI. And this one is his urgent angiography. It revealed the stent thrombosis on the proximal of the mid OCA. Predilatation with compliant and non-compliant balloon was performed repeatedly along the mid to distal OCA. We failed to restore the flow. Then, multiple pass thromboaspiration was done. However, the distal flow still persistent TME0. So, flash cocktail was delivered to the distal OCA by using aspiration catheter. After that, we got result TME1 at the distal part and light thrombus burden in the mid part. Thromboaspiration was performed again and we got some light thrombus. Angiography revealed the severe stenosis of the mid OCA. 2 stents was deployed at the lesion successfully with good result. Patient going well and discharged and dead sweat. To that, the exact cause of the no-reflow remains elusive. But distal embolization, reperfusion injury, and ischemic injury seem to play an important role in STEMI patients. The incidence of no-reflow increase outdoor to balloon time increase, and it correlates with high thrombic burden. While it happens, it usually associated with early post-infarct complications, late repeat hospital stay for heart failure and mortality. There are a lot of experimental data showing the effectiveness of treatment. According to Park et al., case report found that nitroglycerin improved the TME flow rate. However, it's used in post-PCI and needs several injections. Another study, Fisher et al., inject of nicardipine and adenosine under flash cocktail can remain no-reflow. But this technique was used in rotational atherectomy and non-acute MI. In contrast, Baru and al. Report the case series using intracorneal thrombolysis at the flash, and so it improved the flow, reduced thrombus, and facilitated revascularization. However, this can select only the patient with early presentation. So and al. Inject nitrofuran and tirofiban through the aspiration catheter so it prevents no-reflow in STEMI patients. But patients with late presentation and cardiogenic shock was excluded, whereas the other group of high risk the thrombus burden and no-reflow. Similarly, Ponechi using nicotine and contrast and found it reduced no-reflow and had 2 side stents. However, all this study was not by 2 vasodilator and anticoagulant. Up to present, there are many drugs are recommended to use testing no-reflow. The more common use are GP2B3A inhibitor, adenosine, and nicotine. However, these drugs are not available in our center. So, we modify by combination of 2 vasodilators, Verapamil and Nitroglycerin, plus 1 anticoagulant heparin. In our experience, the combination small dose of these 3 drugs increase effect and has less side effect. Instead of microcatheters that are not available in our center, we have used aspiration catheter and homemade side-hole balloon as a delivery device. By using device, drug can reach the region. We got the effective result and less risk, so we can save as much as we can. In our experience, the method is always available, easy, fast, and economic. However, we are not sure if the technique can be adopted universally. Randomized try it. Take home message and learning point. Minimization of clot manipulation have to prevent no-reflow during primary angioplasty. If no-reflow occurs, intracoronary injection of vasodilator has been used. Combination drug increase success and help in choosing the right strategy, the correct side of the stent, and avoid the no-reflow. This method should be used early stage of the intervention for achieve superior results.
Okay, thank you very much. Time for Q&A, please, just. Any questions?
Can I ask a question?
Yeah, yes, Ram.
Yeah, thank you very much for your paper. I was just wondering that there was no control. So how do you know yours is actually effective as compared to another?
Yes, for this condition in our person, the person is going well. We follow up only the clinically and the echography and the EKG. For the coronary angiography, we has done to control that. And as we follow up the clinically, the patient is going well. And during the follow-up, he has no symptoms related to the angina.
So all your patient actually has got an aspiration catheter attempted. And then if failed, then you give your cocktail, is it?
Yes.
Thank you.
Any more questions?
So can I just
yes,
check, routine practice to do aspirations thrombectomy for all myocardial infarctions?
No, in our center, we are not routinely use thrombo aspiration. We use in case the patient come in with a late presentation and have high thrombotic lesion and the thrombosis burden grade more than 3 or 4 classification. That in that condition that we use it.
I see.
Okay.
Thank you.
Yeah.
Yes.
How many patients already performed that procedure in your center?
Initially, we use the technique to treat the no-reflow after the PCI in some cases, and after we saw it effective, so we start to use it in the patient come in late, high thrombotic burden, and while we do the standard technique, we fail to restore the flow. We try to use this technique. From last year till now, we use for around 20 patients by using this technique.
Okay, thank you very much. We move on to the third presentation, correlation between serum Carboxy-Terminal propeptide of type 1 procollagen and fibrosis in rheumatic mitral valve, presented by Dr. Ari Sariningrum from Indonesia.
Good afternoon, ladies and gentlemen. Thank you for the chance that given to me. My name is Ari Sariningrum and I am from Indonesia. I would share about my research, correlation between serum Carboxy-Terminal propeptide of type 1 procollagen and fibrosis in rheumatic mitral valve, a cross-sectional study. I've divided my presentation into a few sections. Rheumatic heart disease is the most serious complication of acute rheumatic fever and currently still being considered as a global health issue, specifically in developing countries. In 2015, it is affecting more than 1 million individuals in Indonesia. Rheumatic heart disease is induced by chronic inflammatory and autoimmune process in patients who develop certain gene susceptibility after group A Streptococcus vira hemolyticus bacterial infection. This process leads to increased collagen synthesis and remodeling of the extracellular matrix in the cardiac valve and myocardium tissue, and it will eventually lead to fibrosis of the cardiac valve. Then the cardiac valve will have persistent severe deformity and dysfunction. The chronic inflammatory and autoimmune response begin with Streptococcus colonization in the throat. Then it will activate the natural immune response. Fibrillar collagen types 1 and 3 are the main components of extracellular matrix in cardiac valves. Fibroblasts and myofibroblasts secrete the type 1 procollagen precursor molecule into the interstitial space. During the maturation process, amino-terminal propeptides and carboxy-terminal will be broken down to produce mature triple helical monomers. Carboxypeptidase hydrolyze carboxy-terminal of type 1 procollagen or P1CP, which through the venous and lymphatic system enters the systemic circulation. One P1CP molecule can be detected in the blood for every type 1 procollagen molecule that is transformed into type 1 collagen molecule. Normally, the speed of collagen synthesis will be balanced by the rate at which collagen degrades. Disruption of this metabolic balance will result in collagen accumulation and fibrosis. In rheumatic valves, the collagen synthesis rate is higher, so the collagen deposition is higher too, and it will cause fibrosis in the heart valve. Fibrosis is defined as overgrowth, hardening, and/or scar formation in various tissues, and it is characterized by excessive deposition of extracellular matrix components including collagen. Meanwhile, histopathological examination is the gold standard in assessing fibrosis. The objective of this study is to evaluate the correlation between P1CP level and the severity of mitral valve fibrosis in rheumatic heart disease patients. 23 subjects with stenosis and/or regurgitation rheumatic mitral valve disease who underwent mitral valve replacement were enrolled. We collect the blood samples before the MVR. Fibrosis of rheumatic mitral valve was examined with mesenteric staining. Quantification of fibrosis was done using imaging software with 6 fields in each sample. The percentage of the total area with positive color for each section was recorded. And this is the results of the study. These are the clinical characteristics from 23 patients. From the histopathological assessment, we can find that cross-examination of mitral valve section from the subject showed leaflet thickening, commissural fusion and shortening, and thickening and fusion of the tendinous cords. In microscopic examination showed inflammation cells, neovascularization, myxoid degeneration, and enhanced fibrosis. At the right picture, we can see the calcification in mitral valve. This is the fibrosis examination using mesenteric staining. Area of fibrosis shown by blue color. For the example, the left picture showed fibrosis in 39-year-old patient with predominantly mitral regurgitation and 43.64% area of fibrosis, and the right picture showed 67.27% area of fibrosis. The mean plus-minus standard deviation for percentage area is 71.5 plus-minus 12.8%. The cutoff value for percentage area of fibrosis between the relatively mild and severe one in our patient is 74.9%. 11 patients have relatively mild fibrosis, while 12 patients have much severe fibrosis. The mean plus-minus standard deviation of serum P1CP was shown in the picture. From Spearman correlation test revealed that P1CP serum has positive correlation with fibrosis in rheumatic mitral valve. Secreted cytokines during the progression of rheumatic heart disease will cause differentiation from valvular interstitial cells to active myofibroblasts. Valvular interstitial cells is the largest cell component in heart valves and produce a variety of extracellular matrix proteins, including collagen. Active myofibroblasts will cause increased production of type 1 and type 3 collagen and will cause fibrosis. In this study, fibrosis was assessed by calculating area that stained blue on the mesenteric staining, which represented the density of collagen. P1CP is released into the bloodstream during synthesis of type 1 collagen, thus considered to be a marker of type 1 collagen synthesis. This supports the correlation between the P1CP level and fibrosis process in rheumatic heart disease patients as described in our data. We can conclude that plasma P1CP level is moderately correlated with the severity of mitral valve fibrosis in patients with rheumatic heart disease. And last, for clinical implication, prevention of tissue fibrosis progression in rheumatic heart disease may become potential therapeutic target. Thank you so much for your attention.
Thank you for presentation. Time for Q&A, please.
I have congratulations. I have a question.
Yes,
Could you explain the findings based on the fibrosis of the mitral valve alone, or is there any other disease of the myocardium that can explain the serum biomarkers that you saw? Thank you. Congratulations.
Okay, thank you for the question. We know that not only in rheumatic valve disease that have increased level of P1CP or fibrosis. So in this study, I have tried to control the confounding factor by using exclusion criteria with patient with condition or disease that may have increased level of P1CP, like with diastolic heart failure or chronic kidney disease in stage 4 or 5, or other disease that have P1CP level that have increased P1CP level. So in this study, after we exclude all the confounding factors, the sample in this study is only we hope only the rheumatic mitral valve. Thank you.
Hi, can I ask a question? Thank you for the presentation. Similar to the previous question, did you control for other kind of echocardiographic parameters or indices? Like is the PICP purely correlating to the valve pathology, or does it correlate to other pathology within the heart?
Okay, thank you for the question. For the criteria, for the echocardiographic criteria for this patient, I use the World Heart Organization criteria for definite rheumatic heart disease. There are some criteria for definite rheumatic heart disease. Like example, for the mitral regurgitation, it has criteria pathological mitral regurgitation with at least 2 morphology features in mitral valve with rheumatic heart disease. And for the mitral stenosis, have a gradient more than 4 millimeter mercury. So with use the definite criteria for rheumatic heart disease in WHO criteria, the confounding factor that some condition or disease that also have the abnormality in mitral valve can be excluded.
I'm Dr. Lam from Malaysia. How do you going to put this into a clinical practice, having known of this knowledge?
Okay. I'm sorry, can you?
Any role of a clinical practice to put it into clinical practice, having done this particular study?
Okay. Thank you, doctor, for the question. I hope after I done this study, I hope that P1CP level should be one of the screening for the rheumatic heart disease patient. And if we know the P1CP level, we can predict how far the fibrotic event that has happened. So we can give some therapy and more aggressive treatment that hopefully we can delay the fibrotic process.
Okay.
Thank you.
Thank you very much. We move on to the next presentation. Global longitudinal strain predict adverse left ventricular remodeling after ST segment elevation myocardial infarction, presented by Dr. Ong Yen Ji from Malaysia.
Good afternoon, ladies and gentlemen. My name is Yen Yi. I'm from Sarawak Heart Center. I'm here today to present my study titled Global Longitudinal Strain Predicts Adverse Left Ventricular Remodeling After ST Segment Elevation Myocardial Infarction. Global Longitudinal Strain, or GLS, measured by speckle tracking echocardiography, is a measure of myocardial deformation and a robust marker of subclinical left ventricular dysfunction. In acute phase of ST segment elevation myocardial infarction, studies have shown that GLS correlates with infarct size and predicts adverse left ventricular remodeling. Our study objective was to determine whether GLS provides additional prognostic value over other echocardiographic variables in patients with STEMI using adverse left ventricular remodeling as a surrogate endpoint for post-MI mortality. Adverse left ventricular remodeling was defined as an increase in left ventricular end diastolic volume 15% or more over 6 months. Our study population was a subgroup analysis of a multi-center prospective longitudinal registry. We recruited 102 patients, 8 patients were excluded. The remaining 94 patients underwent transthoracic echocardiography within 48 to 72 hours of acute myocardial infarction and a repeat examination at 6 months. This slide shows the inclusion and exclusion criteria of the study. We recruited patients aged 22 to 84 years with clinically diagnosed STEMI. Exclusion criteria includes severe renal and liver impairment, anemia, cardiogenic shock, significant valvular heart disease, malignancy within 12 months, and patients with HIV, hepatitis B, and hepatitis C infection. Transthoracic echocardiogram was performed using Philips IE33 or EPIC-7 ultrasound system. The images were analyzed offline in the core lab using TomTec Arena software. GLS was measured using TomTec AutoStrain. We measured endocardial and systolic strain, and the aortic valve closure time was defined using the aortic ejection time. This is our study results. 32 out of 94 patients had adverse left ventricular remodeling. The baseline characteristics between the two groups were largely similar, except for patients in the adverse left ventricular remodeling groups had more diabetes. Anterior MI occurred equally in both groups. Thrombolysis was the main form of reperfusion therapy. Only a handful of patients underwent primary PCI. Multivessel disease were equally prevalent in both groups. On this chart, prescription of ACE inhibitor or ARB and beta blockers were similar in both groups. This table shows the baseline echocardiographic variables. At baseline, both groups had similar left ventricular dimension, left ventricular volumes. The ejection fraction in the group without adverse left ventricular remodeling was 51.4% versus 47.5% in the group with adverse left ventricular remodeling. This difference was, however, statistically non-significant. Patients in the adverse left ventricular remodeling group had lower septal E prime, septal A prime, and lateral E prime velocity. The global longitudinal strain was negative 13.2 in the group without adverse left ventricular remodeling versus negative 10.9 in the group with adverse left ventricular remodeling. This difference was statistically significant. At 6 months, as expected, patients in the adverse left ventricular remodeling group had larger left ventricular dimension, larger left ventricular volume, lower ejection fraction, larger left atrial volume, lower septal and lateral S prime velocity, higher average E to E prime ratio, and wall motion score index. On univariate analysis, septal E prime, septal A prime, lateral E prime, and GLS were predictors of adverse left ventricular remodeling. On multivariate analysis, only GLS is predictive of adverse left ventricular remodeling with a hazard ratio of 1.2, p-value of 0.004. When we included important clinical variables into the multivariate analysis, GLS remains predictive of adverse left ventricular remodeling. This figure shows the receiver operating characteristic curve of GLS in predicting adverse left ventricular remodeling. The area under the curve was 0.64 with a p-value of 0.025. Using a cutoff of negative 12.6%, GLS has a sensitivity of 71.9%, specificity of 54.8%, accuracy of 60.6% in predicting adverse left ventricular remodeling. Our study results are consistent with previous studies that GLS predicts adverse left ventricular remodeling. In a meta-analysis, the cutoff GLS ranges from negative 12.8 to negative 10.2%. In our study, GLS is the sole echocardiographic parameter that predicts adverse left ventricular remodeling. However, in other studies, other echocardiographic parameters such as left ventricular end diastolic volume and deceleration time remains informative despite the use of GLS. This can be explained by the difference in baseline characteristic of our study patient. We measured end systolic strain, which is the default parameter for myocardial deformation according to the latest task force recommendation. Previous studies measure peak systolic strain, and therefore head-to-head comparison is a bit difficult. In addition, we know that in acute phase of STEMI, post-systolic shortening can occur, and therefore measuring systolic strain may not represent the highest strain value. We measured endocardial strain, which represents the innermost longitudinal myocardial fibers. It does not represent transmurality, and we believe this is the reason why the specificity and the accuracy was low in our study. We conclude for our study findings that GLS measured in the early phase of STEMI was the sole echocardiographic parameter that predicted adverse left ventricular remodeling. With that, I thank you.
Thank you very much. Campbell, Q&A, please.
Hi, sorry. Can I just say your AU Sofian from Brunei, thank you for your very nice presentation. Your AUC wasn't that great, I have to say, so this parameter is not that great of a predictor. So what's your comment with that, and how could this be improved?
I think I've explained it in the discussion part. We measured endocardial strain, and that doesn't represent transmularity. And we believe that that is the reason why the accuracy and the specificity is low. Nonetheless, our cutoff value is almost similar with previous study, which uses peak systolic strain. And we think that a value of negative 12% perhaps can be a guide to us, for this group of STEMI patients, perhaps a shorter follow-up or more aggressive up titration of heart failure therapy.
Thank you.
Thanks.
Isman from Indonesia.
Hi.
Are you measure the best timing for measuring the your research, the best timing for echocardiogram for girls?
The baseline echo was within 48 to 72 hours after the diagnosis.
Yes, sometimes after acute myocardial infarction, the myocardial performance increase and becomes better than in the first hour of admissions. Okay.
Hi, this is Lim Chun Wei from Singapore. Thank you for the presentation. I'd like to echo what Dr. Sofian said about your low ROC area under the curve. Did you look at the other parameters? Because you're obviously different between the two groups as well, with adverse or without adverse remodeling, like LVEF or LVESVs and all the other simpler to measure measurements, because GLS is a fairly time-consuming and relatively expensive piece of software to have. Did you look at the other parameters, or even things like other clinical factors like troponin levels, etc.? Thanks.
We do look at, for the echocardiographic parameters, we do look at other parameters as well. We look at the diastolic parameters and also the left ventricle volumes. But in our study population, only left ventricle GLS is the only predictor in the multivariate analysis. As of for clinical parameters, we do not include the biomarkers in our study. We only include clinical characteristic like diabetes, anterior MI, the Calmette class. Yeah, we do not have biomarkers in our study.
Yes.
I can't hear you, Dr. Lam.
Yeah, they do actually compare the deceleration time and look at the GLS in relationship. Are they coincide to each other also at the same time?
No, we do not study the correlation between the deceleration time and GLS.
Doctor, congratulations for your wonderful paper. Are the patients treated equally in your group? For example, specifically statin use? Thank you.
Yeah, the treatment strategy are the same, but whether the treatment outcome, yes, we did not take that into consideration.
I asked statins because I noticed in your table you reported the ACE inhibitors, for example, the beta blockers, but I didn't see statin use. Was the statin use checked? I didn't hear your answer, sorry. But congratulations anyway.
I think the statin use is not included in my slide, but the discharge medications were largely similar in both groups.
Thank you.
Okay, we have to move on. Thank you. Next paper, nutrition and fertility status of patient undergoing cardiovascular surgery and its association with post-operative outcome, presented by Dr. Marian Patricio from Philippines.
Good day, colleagues. I am Dr. Marian Patricio from Philippine Heart Center, presenting our paper entitled Nutrition and Frailty Status of Patients Undergoing Cardiovascular Surgery and its Association with Post-Operative Outcomes. For the background of the study, malnutrition is nutrition imbalance as a result of overnutrition and undernutrition. Undernutrition is more common in critical illness due to lack of caloric intake. Critical illness also results to increased caloric requirements, poor nutrient absorption and utilization, and inflammation. Cardiovascular surgery post-operative patients admitted at intensive care are at an increased risk of malnutrition. Unique to cardiopulmonary bypass is the intensity of the inflammatory response, which may be aggravated by pre-existing malnutrition. The diagnosis of malnutrition results to significant use of resources due to its complications. Malnourished patients who underwent cardiovascular surgery have increased risk of prolonged ventilation and nosocomial infections. This results to a prolonged hospital stay with a higher risk for mortality. Despite its effects, malnutrition prevalence is increasing across the world because of under-recognition and aging population. In the hospitalized elderly, malnutrition has a prevalence of 38%. In patients undergoing cardiac surgery, the prevalence is 46%. In one local study in a Baguio hospital, the prevalence was high at 73%. Due to differences with screening and diagnosis, the European Society of Parenteral Nutrition has convened to streamline the guidelines. The Global Leadership Initiative on Malnutrition Criteria was formed. However, lack of validation for Asian populations preclude its widespread use. Nutrition Risk Screening 2002 was endorsed by ESPEN. NRS has been widely used and validated in Asian and cardiac surgery populations. It is composed of screening, assessment, and diagnosis. The following are used for screening. Nutrition risk assessment is then completed using the following graded criteria. Mild to moderate malnutrition is diagnosed from a score of 1 to 2, while severe malnutrition is diagnosed from a score of 3 and above. Malnutrition is a central component of clinical frailty, which is a syndrome characterized by poor nutritional status, weakness, reduced cognitive function, resulting to susceptibility to stressors. It is more common with aging individuals as part of age-related decline. However, in contrast to aging, frailty is associated with increased inflammatory markers with higher odds of dying compared to non-frail individuals. Frailty has been recognized as a condition that affects cardiovascular surgery outcomes. Higher risk of complications arise with frail patients undergoing cardiovascular surgery. There are a number of validated frailty tools to screen and classify frailty. This results in differences in assessment of frailty measures such as muscle strength, muscle volume, movement, cognitive decline, and activities of daily living. special tools and imaging preclude routine assessment of inpatients. Hence, the Canadian Society of Health and Aging developed the Clinical Frailty Scale as a simple interview tool for determining level of frailty. CFS is a 9-point exam with frailty being defined as a score of 4 and above. It involves history of patient's mobility, self-care, cognition, and activities of daily living. It is highly correlated with a more comprehensive frailty index and has been validated across various populations, including cardiac surgery patients. Frailty has a high prevalence of 30% in a systematic review. For patients undergoing cardiac surgery, the odds ratio is 4.89 times for major adverse cardio and cerebrovascular events. Studies of frailty in developed countries involve old age more than 65 years old with delayed degenerative diseases. To date, there are no published data on malnutrition and frailty in cardiovascular surgery patients. There is limited data specifically addressing frailty in the younger adult. Hence, my general objective is to determine the in-hospital post-operative outcomes of adult patients with malnutrition and frailty admitted for cardiovascular surgery, and these are my specific objectives. Research population involved adults 19 years old and above admitted for cardiovascular surgery. Intervention was malnutrition and frailty, outcome was post-operative outcomes, and method was prospective cohort. This study was conducted from October 2020 to February 2021. Online census was accessed daily for eligible patients. Adult patients 19 years old and above admitted for cardiovascular surgery were included. Excluded were those who refused to give informed consent and unable to answer questions from CFS and NRS. Once eligibility criteria was met, informed consent was obtained, clinical profile was collected, NRS was used to determine nutrition status, and CFS was used to determine frailty status. Patients then underwent cardiovascular surgery. Patients were followed up daily until outcomes of interests were observed until discharge, and these were the statistical analysis done. For the result, the total population was 111, with a mean age of 53 years old, 63% were male. CABG was the most common surgery, followed by valve surgery, hypertension, chronic kidney disease, and heart failure were the most common comorbidities. This table compares two groups, no malnutrition versus malnutrition in the topmost row and variables of interest in the leftmost column. The diagnosis of malnutrition was noted in 51% of patients admitted. Malnutrition was found in older patients with a mean age of 57 years old. Surgery for rheumatic heart disease, mitral, and multi-valve surgery were significantly associated with malnutrition, and surgery for ASD had lower prevalence of malnutrition. Among comorbidities, heart failure and chronic kidney disease were significantly associated. Lymphopenia, lower total protein, and higher creatinine were lab data significantly associated. This table divided patients into three groups, no frailty at risk and clinical frailty on the topmost row, and the different variables in the leftmost column. 23% of the population had frailty and an additional 16% are at risk. Similar with malnutrition, age, RHD, mitral, and multi-valve surgery are associated with frailty. On comorbidities, heart failure, chronic kidney disease, thyroid disorder were significantly associated. On lab data, lymphopenia and high creatinine were associated with frailty. This table shows the outcome of interest on the leftmost column compared in between three groups in the topmost row, namely normal, malnutrition, and malnutrition with frailty. We see that mortality, prolonged hospitalization, duration of mechanical ventilation, and nosocomial infections were prolonged with malnutrition and frailty. This table shows the odds ratio of patients with malnutrition of having an outcome compared to normal reference. The odds of having composite outcome is 5.32 times compared to normal reference. The presence of frailty on top of malnutrition puts the patient at higher odds of having an outcome at 11.97 times compared to normal reference, and both are statistically significant. The prevalence of malnutrition is 51% in this study, higher compared to 46.4% reported by Lopez et al. A reason for this is significant proportion of RHD, which parallels higher prevalence of malnutrition in low to middle income countries. Another possible reason is that this study was done during COVID-19 pandemic with delays in elective surgery resulting to prolonged symptoms of heart failure. Heart failure is a known risk factor for malnutrition, a well-described condition called heart failure cachexia. This also results to renal insufficiency, compounding the effects of malnutrition. The prevalence of frailty in this study is 23%, within the range for cardiovascular surgery populations of 4.1 to 46%. Mean age in this study is younger, 59 years old, compared to systematic reviews of frailty in developed countries with age range of 65 to 79 years. Possible explanations include earlier onset of atherosclerotic cardiovascular disease with significant number of RHD occurring in younger adults. The composite outcome for events in this study was 11.97 times higher than the reported odds ratio in a systematic review. The clinical implication of higher prevalence of malnutrition and frailty, its effect on post-operative outcomes, is the importance of screening and management. strengthening clinical pathways and tailoring a specific nutrition therapy for these patients are also recommended. Cardiac rehabilitation mitigating frailty syndrome cannot be overemphasized as it is also associated with improved outcomes. In conclusion, evaluation of nutrition and frailty status using NRS and CFS was helpful in predicting post-operative outcomes. With a significant number of this population having malnutrition and frailty, there is a need to strengthen clinical pathways in peri-operative nutrition and rehabilitation with the possibility of improving cardiovascular surgery outcomes. Thank you.
Thank you. Q&A, please. Any questions from the judge?
Congratulations on your abstract. This is Dr. Lim Tunwai from Singapore. I was wondering whether, there's a large proportion of patients with malnutrition and frailty in your cohort. Were there any specific interventions that were used in these patients, and did that make any difference? Thank you.
Thank you for your question, Doctor. We use the nutrition risk screening tool as part of our clinical pathway in our center. However, there have been modifications for the application of this pathway because of the lack of face-to-face intervention. And I think that the lack of face-to-face intervention will also affect the delivery of service in our hospital. Thank you.
Any more questions? No more questions. Thank you very much. Move on to the next presentation. Clinical and echocardiographic differences between rheumatic and degenerative mitral stenosis, presented by Dr. Leo C. Lian from Singapore, please.
Good afternoon, professors, colleagues, ladies and gentlemen. Thank you for attending our presentation, The Differences Between Rheumatic and Degenerative Mitral Stenosis. We know that native valve mitral stenosis frequently occurs because of these very distinct etiologies, and in particular, degenerative MS is said to be increasingly common in the developed country setting. We think this is because of the association between mitral annular calcification, which leads to degenerative MS, as well as conditions like diabetes, the metabolic syndrome, coronary artery disease, and renal impairment. Severe degenerative MS is not a benign condition and can be associated with poor outcomes without intervention. Unfortunately, interventional strategies are not well defined in this group of patients. To our knowledge, relatively little is known about degenerative MS, and in particular, the trends in increasing incidence have not previously been quantified. We think that epidemiologically, this information is very important to understand the changing nature of mitral stenosis, and we also need to know more about the determinants of mortality and other outcomes in these two groups of patients so as to guide management strategies and identify patients who may best benefit from intervention in these conditions. Therefore, in this study, we wanted to evaluate the differences between these two groups of patients, to quantify the increasing incidence of degenerative MS, and to understand the determinants of mortality in patients with these forms of mitral stenosis. Therefore, we set out to conduct an observational study of 745 consecutively newly diagnosed cases of native valve mitral stenosis at our center from 1991 to 2017. This was a retrospective study with data obtained from the electronic medical record and echocardiographic data being interpreted according to contemporary valvular heart disease guidelines. Mitral stenosis was defined according to an area of less than 4.0 square centimeters, and the etiology of mitral stenosis was also indicated by the reporting cardiologist. We took our data and interpreted according to descriptive as well as inferential statistics. We performed a multivariate analysis with Cox regression, and a p-value of less than 0.05 was taken as statistically significant. Of our 745 cases, 75% were rheumatic and 25% degenerative in etiology. The median time of follow-up was 7.25 years, and 38% had passed away during the period of follow-up. Patients with degenerative MS were overall older and they had a higher body mass index. There were no sex differences between these two groups of patients. In our local Singapore context, there was a differential distribution of ethnicity between these two groups of patients. patients with degenerative MS were more likely to have conditions like diabetes and hyperlipidemia, as well as ischemic heart disease and renal impairment. Conversely, those with rheumatic disease are more likely to have AF as well as a previous stroke or TIA. In terms of the echocardiographic data, the average patient had severe mitral stenosis with an area of less than 1.5 square centimeters. Those with rheumatic disease had more severe mitral stenosis, they had a greater left atrial enlargement, and they had a higher pulmonary artery systolic pressure as well. At the same time, we also captured data about coexistent valvular heart lesions. We found a differential pattern of associations, where degenerative MS is more often associated with aortic stenosis, and rheumatic MS more often associated with mitral and aortic regurgitation. This raises the possibility that degenerative MS may be associated with a systemic calcific process that also may give rise to aortic stenosis at a higher prevalence. Perhaps the most important finding in our study comes in this slide, where it shows an increase in the relative incidence of degenerative MS over time at our center. At the start of our study period, almost all cases were rheumatic, but towards the end, 41% were degenerative. This suggests an epidemiological change in the etiologies of mitral stenosis, and we believe it may be related to the demographic changes in Singapore with an aging population and a higher prevalence of conditions like diabetes in this time period. At the same time, comparing survival data at the 10-year mark, there is an apparent survival difference between these two conditions. However, once the survival analysis was performed, we found that the etiology of mitral stenosis did not influence survival in the multivariate analysis. Rather, it was undergoing mitral valve intervention that was most strongly protective. At the same time, age and ejection fraction were also identified as risk factors for all-cause mortality. In a group of patients with severe mitral stenosis, we found similarly the etiology of mitral stenosis did not influence survival. Rather, it was mitral valve area that was now found to be a predictor of mortality in this subgroup. Overall, in terms of our findings, we have found consistent associations between degenerative MS as well as metabolic comorbidities and rheumatic mitral stenosis with conditions like AF and stroke. This is similar to contemporary findings, including a major study that compared cohorts in the United States as well as South Korea. And in our developed country study, we found a clear trend towards increasing incidence of degenerative MS. In comparison to previous point estimates in the United States as well as Europe, which yielded 6 to 12%, we found 41% in the most recent time period. The etiology of MS did not affect all-cause mortality in our study in the multivariate analysis, and rather it was undergoing mitral valve intervention that was most strongly protective, while increasing age and lower ejection fraction were adversely associated with increased mortality. In the subgroup with severe MS, a more stenotic valve area was also adversely associated with all-cause mortality. This study raises several interesting implications. We think that in our Singaporean study population, the relative incidence of degenerative MS may be related to the ongoing demographic transition with a much increased prevalence of diabetes as well as increasing lifespan and population aging. This is because of the association between mitral calcification and these conditions. This is an important finding to other countries in the region who are likely to face similar issues with increasing life expectancy and an aging population in the setting of rapid socioeconomic development. At the same time, attention also needs to be given to identifying interventional strategies for patients with degenerative MS, given that they were not at any lower risk for mortality and that mitral valve intervention was strongly protective on survival in our multivariate analysis. Thank you very much.
Thank you. Any questions from Jess?
Thank you very much. That was a very interesting presentation. It covers about a 30-40 year period. So I'm just wondering about two things. One is that the technology for echo has changed a lot over 40 years. And as well as that, the appreciation of this diagnosis may have changed in the last 40 years. How do you adjust for that in your study with such a long time frame?
Thank you very much, sir. Thank you for the question. So because of the historical nature of the data, some more contemporary parameters were not able to be reported because they were not routinely measured at the start of the time period. For instance, left atrial volume index, which is now contemporarily used to analyze the degree of left atrial enlargement. Secondly, at the same time, there were also a few cases where the etiology of mitral stenosis was not clearly indicated. In such cases, the raw images were reviewed by 2 consultant cardiologists at our center in order to indicate the final diagnosis.
Thank you.
Please, Jude. Yeah. You are unmute. Can't hear.
You have to unmute yourself.
Yeah, unmute, please.
Oh, sorry. Congratulations, doctor. Just briefly, I saw that in your paper, you included in the analysis patients who are not all pure MS, but with concomitant diseases like aortic stenosis. Could you justify the inclusion of those with other valvular lesions in your study?
Thank you very much, sir. We appreciated that, especially in patients with rheumatic heart disease, oftentimes they may suffer from polyvalvular disease, and therefore we also wanted to capture an appreciation of patients with other concomitant valve lesions. In fact, this also raised up interesting findings, like we saw the different pattern of associations between rheumatic and degenerative MS, and we think it's an interesting direction to analyze our data further.
My question is, would you like to present a paper wherein it's only pure MS and no other concomitantly? Do you have an analysis of only pure MS? Thank you. And congratulations.
Thank you very much. We do have a subgroup of patients according to the presence or absence of other valvular heart disease, but we chose to present the data for all our patients because, for instance, a lot of patients with rheumatic mitral stenosis also had concomitant valve lesions, and therefore the number with pure MS alone was relatively lower. Similarly, for those with degenerative mitral stenosis, oftentimes they may also have a degree of mitral regurgitation, especially those with a degree of ischemic cardiomyopathy, and a similar process also applies.
Thank you. Last question.
Now, you correct me if I'm wrong. Did you actually look at the morphology and the differences between the rheumatic mitral stenosis and the degenerative mitral stenosis? I know that you mentioned about the size and all, but did you look at the characteristic morphology of the valve?
Thank you very much, Dr. Lam. Yes, sir. This was actually taken into consideration when the etiology was determined. For instance, some changes that were taken as diagnostic for rheumatic MS were the presence of commissural fusion, as well as a doming of the mitral valve leaflets. The absence of these changes, together with a high degree of mitral valve calcification, was taken as favoring a diagnosis of degenerative mitral stenosis.
Okay, thank you. We have to move on to the next presentation. Electrocardiographic model to predict cardiac resynchronization therapy response among chronic heart failure patients, presented by Dr. Patrani Lila Patana from Thailand.
Good afternoon, Mr. Chairman and colleagues. It's my honor to be here today. I'm going to talk about electrocardiographic model to predict cardiac resynchronization therapy response among chronic heart failure patients. As we know, we have other options besides medications for those heart failure patient reduced ejection fraction patients, especially those with LV dysynchrony. And I am referring to a CRT. However, there are only 2/3 of the patients that achieve CRT response. Other 1/3 are non-responders. As you can see, the good predictive parameters for CRT response are important but imperfect yet. One interesting thing is that the patient's ECG can reflect the conduction delay. The more the delay means that the more the dysynchrony, so the more the response. This marker I am going to talk about is called the time to intrinsic coil deflection. And this is the time to intrinsic coil deflection, the duration from the beginning of the QRS complex to the average peak time. In short, as you can see, there are the walls that have the delay and that reflects on this ECG. The blue is good while the red is not. Look at those fragmented QRS complex with delay time to intrinsic coil deflection. For SVF in V1 and RVF in V6, the higher the number, the more likely the true LBBB, and of course, the better the response. So this is another interesting marker. Combining these markers together, we try to get our new model for predicting CRT response. So, objective of our study is to get a simple model from the CCG to predict the CRT response among chronic heart failure patients. This is a retrospective cohort study of the heart failure patients underwent CRT implantation in our hospital in the past 14 years. Our inclusion criteria is a standard indication for the CRT implantation according to the ACC and ESC guideline. And we excluded those with the upgraded CRT from the pacemaker, those who had intervention 6 months prior to CRT implantation, and of course excluded those who lost to follow-up, lost either ECG or echo data, and those with implanted with LV epicardial lead. And this is what we are measuring: the QRS duration, and SVF amplitude, and time to intrinsic deflection among the ECG leads. From these parameters, the following value has then been calculated. The ICC for intra and inter-observer variability will also calculated. We use the newest criteria for LBBB according to 2018 ACC guideline for bradycardia. After 6 months of CRT implantation, the patient's responder data were recorded. Either a 10% improvement of LVEF or a 15% reduction in LV and systolic volume is required. As for the results, this table showing the baseline patient characteristics in both responders and non-responders. As you can see, there was not much difference between the two groups. From the significant differences, non-responders had more atrial fibrillation at the time of implantation and had higher baseline creatinine. For the baseline ECG, there were such great differences from the beginning. As you can see, responders had more LBBB, had greater reduction in QoS complex duration after implantation, and had greater values of calculated parameters as shown. Multivariate analysis showed that the independent parameters for CRT response were the more the reduction of the QoS complex duration after implantation, the higher the ratio of intrinsic deflection in lead 1 to QoS ratio, and the higher the value of calculated R and SVF in lead V1 and V6 as shown. So we use all those significant parameters and create this equation. The area under the ROC curve for this new equation in predicting CRT response was a 0.85. It is not a surprise that those responders had much better survival than those without responders. This study, those non-responders. This study investigated the ECG parameters as well as clinical predictor of CRT response in symptomatic chronic heart failure patients who met current guideline recommendation for CRT implantation, which we found these three as independent parameters for CRT response. A score of more than 0.3 show high sensitivity and specificity for prediction of CRT response. I think our model is useful for decision making before CRT implantation. However, we may have to implant the CRT anyway as per guideline, but this predictor may be useful as a patient counseling beforehand. For example, this patient, the two patient, has been consulted for CRT implantation. Regarding to the equation, we have this intrinsic deflection in lead 1 to QoS ratio, and this S in V1 and R in V6 prior to implantation. and use our new score. This is a post-CRT implantation. The QS duration was narrowed down to a 139 milliseconds. By using our new model, the calculated result was equal to 2.9. What we do expect from this patient? As this is 2.9, which is more than 0.3, we expect that this patient will have a good CT responder. And that's true for this patient. On the other hand, if the result is less than 0.3, there is a high probability that that patient will not achieve CT response, which we might consider for an early referral to alternative treatment, such as heart transplantation or LVAD. From this study, we have some limitations. In order to manually calculate it to the time to intrinsic deflection, most physicians will not familiar to this, and this may lead to an inter and intra-observer variability. Other than that, this study limits to the symptomatic chronic heart failure patients only, which we cannot apply to other indications for CRT, such as those upgraded from the pacemaker. Lastly, as it is a retrospective cohort study, we only have a post-CRT echo result as an improvement marker for CRT response. We didn't have any data for 6-minute walk test or quality of life questionnaire. In conclusion, in order to predict CRT response, this presentation proposed a new ECG model with a cut point of 0.3 as an add-on predictive value for CRT response. And thank you very much for your attention.
Thank you. Any questions from the judge?
Okay, so that's a very nice way of quite impressive outcomes. But I was wondering actually, a lot of it, the value comes from the delta QRS before and QRS after. How good is delta QRS as a predictor of response in your population, pre and post? Just simply the difference alone, without putting it into your equation.
Thank you very much for your question. As you know, the more the reduction of the QRS complex can predict quite very good in the previous study that to predict the CRT response. However, in our study, of course, the more the reduction of the QRS complex pre and post implantation can independently predict the CRT response. But when you add on more the score, like the more the conduction delay in the delay in intrinsic deflection in lead 1, and the more the delay in S-wave in V6, S-wave in lead 1 and R-wave in V6, our score can give more specificity to predict the CRT response.
Thank you.
Thank you. If no more question, I would like to move on to the last presentation. Association of angiotensin converting enzyme insertion deletion gene polymorphism with coronary lesion severity and prognosis in patients with acute myocardial infarction, presented by Dr. Tran Khong Doi from Vietnam, please.
Ladies and gentlemen, I'm Dr. Tran Khong Doi from Vietnam. Today I'm honored to present our study on the topic association of angiotensin converting enzyme insertion deletion gene polymorphism with coronary lesion severity and prognosis in patients with acute myocardial infarction. The Human Genome Project has had an enormous impact on the emergence of personalized medicine because it allowed the opportunity for making individual prediction about disease risk and helps somebody choose a prevention plan that is right for them. Despite the advancement in the diagnosis and treatment, acute myocardial infarctions remains the leading cause of mortality worldwide. The pathogenesis of myocardial infarctions involve complex interactions between genetics and environmental factors. The estimated heritability of myocardial infarctions is from 50% to 60%. There have been various genetic risk factors of myocardial infarctions. These did encode protein in different pathophysiologic processes, including feeding angiotensin aldosterone system, in which ACE genes is one of the most common studied genes. The most prominent polymorphism in the ACE genes is the presence or absence of 287 base pairs. Insertion in intronzig on the gene 17 chromosomes. Subjects with 1 or 2 G allele have approximately 25% and 50% higher ACE level than subjects with the II genotype. A 50% increase in ACE level should result in a rise in the level of angiotensin II. Angiotensin II results in vasoconstriction, muscular hypertrophy, and fibrosis. The release of aldosterone, which leads to sodium and water retention. The study was asked to assess the association of angiotensin converted enzyme insertion deletions, gene polymorphism with coronary lesion severity, and investigate the role of ACE-ID genes polymorphism in predicting 1-year mortality among acute myocardial infarction. This was a robust cohort study among patients with the first AMI diagnosed according to the 4 universal definition of myocardial infarction and Cambodia Hospital, Vietnam, between January 2020 and June 2020. All patients were followed up until 12 months from admission. ACE-ID genotype testing was conducted by the ASO-PCR method. DNA was extracted from 2 millimeters of peripheral blood, and the result of genotype testing were II, ID, or DD. A total of 130 patients with the first acute myocardial infarction were enrolled in the study. Their mean age was 65, mean accounted for 67. The rate of patients with ST segment elevation myocardial infarctions were 51%. Dyslipidemia and hypertension were the most common cardiovascular risk factors, and 23% with Kili plus equal to or greater than 2. The proportions of trivaso disease is 35%. The most affected coronary arteries were left anterior descending artery, and the mean density score was 42 points. The frequencies of II, ID, and DD genotypes was 42, 41, and 16% respectively. DD genotype carrier had a higher mean density score than patients with ID or II genotype, but the difference were not statistically significant. The AMI patients with DD genotype has a tendency to have lesion in left anterior descending artery and 90% stenosis of at least one coronary artery. The 1 year of cause mortality events occurred in 13% of patients. The DD genotype were associated with the total mortality on a unitary variable regression analysis. This relation remains significant after adjusting for confounding factors, including age, gender, diabetes, Kili class equal to or greater than 2, and ACE-DD genotype. The Kaplan-Meier showed that AMI patients with DD genotype had lower cumulative survival probability than II and ID genotype group. YE ACE-ID genes polymorphism associated with mortality in AMI patients. The renin-angiotensin conversion system plays a significant role in the cardiovascular continuum, and the important active component of the renin-angiotensin system is angiotensin II. Subjects with DD genotype had approximately 50% higher ACE level than subjects with the II or ID genotype, which result in a rise in the levels of angiotensin II. Angiotensin II promotes remodeling of heart and vessels and plaque progression after acute myocardial infarction, which eventually leads to mortality. In conclusion, the genotype carrier with AMI had higher mean density score than patients with IG or II genotype, but the difference was not statistically significant. In patients with AMI, AACE DD genotype were an independent predictor for 1 year on mortality, and this genetic variant may play a futuristically promising role in the prognosis after acute myocardial infarction. Thank you for your attention.
Thank you. Any questions from the judge? If we have no question, thank you very much, and the result will be announced at the closing ceremony today at 5 p.m. Cambodia time. Thank you very much for all presenters, and thank you very much for all judges. I would like to close the session. We have to move on to the next session. Thank you very much, everybody.